On behalf of the University of Calgary Section of Orthopedic Surgery and the Orthopedic Chairs of Canada COA Committee, I would like to welcome you to the 2025 National Grand Rounds in honor of the fourth annual celebration of Canadian Orthopaedic Care Day. It gives me great pleasure to introduce our lecturer today, Professor Faris Haddad. Professor Haddad is a hip and knee reconstruction surgeon at University College Hospitals in London, UK. He is the Divisional Clinical Director of Surgical Specialties at UCH and Westmoreland Street, and the Director of the Institute of Sport, Exercise and Health at University College London. He has presented and published widely on key aspects of hip and knee surgery and continues to lead clinical research groups in robotically assisted surgery, among many other research interests. He is also the editor-in-chief of the Bone and Joint Journal. Professor Haddad, thank you for joining us as our fourth annual speaker for National Grand Rounds.
Jason, thank you very much for the invitation to speak today. It's a great privilege to be invited and to be with you and to speak on robotic hip and knee surgery, our journey from innovation to evidence-based, which is, of course, something that's ongoing. I'll try and cover this topic in the way that we've gone through it in the United Kingdom, and I hope it will bear some relevance to everybody in Canada and provoke some thinking and perhaps some change in this area. I should start, as we always do, by declaring my conflicts. There are many, and they are particularly relevant in this presentation, as I will be speaking about a Stryker product primarily, and I do undertake research with Stryker and receive royalties from them, and I'm a consultant with them. So I think you need to bear that in mind all the way through, although I'm going to cover that in the next slide as well. The other very relevant disclosure is that I chair the Robotic and Digital Musculoskeletal Initiative at the Royal College of Surgeons in England, so have been involved in driving this area from a central perspective, not just focused on research, but also on training and education. Now, one of the key things to flush out, if you like, one of the big elements in the room with this topic is that robotics and computer assistant and all enhanced technologies in arthroplasty are linked to industry in one form or another. And that creates challenges for us. There are practical challenges because often these are closed platforms and therefore they would wed you to individual implants that you may or may not particularly like or are not used to for using this technology. And that's a challenge for some people. But also because the technologies are in different levels of their progress, their evolution, the science and the data behind them, that can create very strong tribal views and conclusions. If your team is winning, you may be happy. If your team's not winning in this area, you may be against this particular direction of travel. And I think it's important to bear that in mind when you look at it in terms of the bigger picture. And that in turn leads us to doubt a little bit of the evidence that we see, because the reality is the literature these days is incredibly open. It's possible to publish many things. So differentiating really good science from junk is pretty hard. And that's where we need to be cautious and we need to look at data very critically. And sometimes people mistrust the literature for good reasons. And sometimes we should, of course, listen to the literature, which should guide our practice. So I think one of my other roles as editor of a journal is really focusing on the highest quality data. And I'll allude to that a little bit here because a lot of what we pin our thinking on in orthopedics are case series, experiences, and is data from people who are conflicted or data funded by industry. But I would add as a rider here that whatever you feel about all of that, the reality is the progress we have made and the progress that we are going to make in terms of technologies and in terms of implants requires investment and requires partnership. And that partnership is going to be with industry. So we would really struggle without that. Now, there may be people listening to me who feel that we have solved hip and knee arthroplasty and we can stick where we are forever. And that may be all some places can afford. But the reality is, if we're going to move forward, we still need to continue to innovate. And in order to do that, I would say we should do it in partnership. And the last thing I would say by way of introduction is I still think you are extremely fortunate in Canada because you don't face some of the challenges we face in the UK and Europe with this increased stringent regulatory framework that is EU MDR or UK CA, which is really clamping down on our ability to innovate. Now, that there are some good sides to that, but also there are some serious challenges within it. And again, if we were together in person, that is something we could discuss. And I also recognize you face your own challenges in Canada, of course. So where are we right now with robotic arthroplasty? And in reality, this is a very broad space. This is the space that was occupied by navigation. This is, if you like, the natural progression, but it's got a variety of systems, some of which are fully active, some of which are semi-active, some of which are image-based, some image-less, a lot of different effector arms and some in evolution. And there are also open, and as I mentioned earlier, some closed platforms, which create its own challenges. I'm largely going to talk about CT-based planning and robotic arm assistance with Mako, because that is where we've built up the biggest evidence base, and that's where we've done our own research, both in my institution and in the UK, so to share some evidence with you. And that is one version of robotics, which has a CT scan to create a virtual 3D model. You plan on that model. There's a robotic device to execute, and then there's an intraoperative plan that can be fine-tuned based on balance, on position, intraoperatively. Now, what we have seen through this, if you want to summarize it in one slide, is that there is better accuracy of implant positioning. We're seeing fewer outliers, and that although there is a learning curve for surgeons and operating room teams, there isn't a learning curve in terms of implant positioning. If you define a target, you can hit that target straight away. We can also do really nice things for the hospital, predict implant sizes, predict what sets we need, be able to manage our inventory well. There's good data both in the knee and now in the hip to show less periarticular soft tissue injury. We've seen better early functional rehabilitation, although that's an area where bias from patients and bias from surgeons may come into it to a certain extent. In the UK, we've seen reduced time to hospital discharge. And one area that I'll come back to briefly, but that we really haven't talked about much, is safety, because in reality, there is a safety net here at multiple levels in terms of not being able to cut things we shouldn't cut. And around all of that, there's a huge appetite for enhanced technology worldwide. I really have worried when I've been to Canada over the last few years that you have not been given the opportunity to embrace this technology and move forward. Beyond all of that, as I've kind of alluded to already, there are many systems. So when you look at the data and the literature, you've got to do that for each system separately. You cannot translate from one to the next. And there's one other thing here that's worth thinking about when you're assessing this for your own practice or for the future of your practice or the future of your thinking in arthroplasty surgery, that the systems we're using now are not going to be the ones we're using in 5, 10, or 15 years. This is a step on the journey. It's the principle and what we're trying to achieve and whether we can achieve it that really matters, because the computers, the software, the engineering is moving at dramatic pace. But key message, there are lots of systems out there. All of them have some merits. I think all of them are helpful in that they're illustrating a direction of travel for our specialties in hip and knee surgery in terms of helping the surgeon as tools to define and execute a plan. And I think that is key. But each one of those has to really be developed and deliver its own data sets for us to be able to trust it and move forward with it. Let's start briefly with unicompartmental arthroplasty. I think that's a great model on the basis that this is a wonderful operation with low morbidity, low mortality, works extremely well for both medial and lateral arthritis, but it's got a really fine margin for error. It's effectively a resurfacing. It's an ideal model for us to embrace technology. We know people fail their unis because of over or under correction. We know that people fail because of technical error. If we could introduce a device that reduces those problems, that should help. And that's certainly what we've seen. We've seen accuracy of alignment and positioning, and we've seen multiple studies with extremely good results using robotic arm assistance for unicompartmental arthroplasty, to the point where certainly in my institution, my colleagues have lost equipoise. It's the one randomized study we're unlikely to get to completion because surgeons no longer want to do this operation manually when they can access technology to do it. As I say, the evidence base is strong, and this is probably the strongest piece so far. This is the 10-year data from Mark Blythe's prospective randomized study that basically shows that it is cost effective. So this is one of the challenges with robotics, is even if you like the technology, even if you embrace the idea of personalized arthroplasty, there is a cost involved in terms of procurement. There's a cost involved in terms of disposables. There may be a time cost at the beginning, so on and so forth. And yet here we are with a 10-year study that suggests that is cost effective. And it's a high quality study from that point of view. The next challenge is, of course, showing generalizability, and that's where registry data is coming in. Registry data is interesting because it's not always going to capture all the detail we need for robotic studies. It certainly doesn't capture the imaging. It may not capture the alignment we aim for example, in total knee arthroplasty. But in unis, there is a good signal, both from Australia and from our North American colleagues, to suggest that there is something positive here to go after. And then there's, of course, the philosophy that you face. And this may be a step too far for many people, but the reality is preserving the ACL for some of us is a holy grail. And getting to a point where we can do arthroplasties with ACL preservation, one way of doing that is going to be with compartmental arthroplasty. And there are, as many of you will know, some studies like the truck trial that are already ongoing, trying to look at that and trying to leverage this technology to deliver that. Now, what about total knee arthroplasty? That's where most of you are. Unis have their passionate supporters, but the big thing is total knee arthroplasty for our patients, where there is an unmet need and a huge resources spent doing knee arthroplasty in all of our countries. And I think the key message here is that the goals of total knee arthroplasty have evolved. They've evolved from it being an operation that was just for pain relief and durability to being something where patients want full function, they want satisfaction, and where possible, a forgotten knee. And at the heart of that has become a form of personalization, because we recognize that not all patients are the same, and that some patients require a different joint line obliquity and all require an element of MCL isometry. And if you're going to have a moving target, if you're going to aim for alternative alignments, that's where enhanced technologies such as robotics have got to come in. I won't spend too much time on this, but I think we now all know that knees come in all shapes and sizes. There are CPAC 5s, which are our traditional mechanical knees. There are navigation patterns that are straightforward and others that are more complex. And then there are all sorts of morphotypes. But in reality, we are all now thinking about alignment and what alignment we should be aiming for each and every patient. And I would urge all of you, if you haven't moved on with this topic, perhaps access this summary review that we wrote in the journal, essentially depicting and illustrating the various alignment strategies that people are following right now, from traditional mechanical and anatomic all the way through to kinematic, inverse kinematic, restricted kinematic, and functional. And really understanding all of those and understanding that all our patients aren't the same is important, but also recognizing that if we're not doing the same thing for everybody, we probably need a little bit of help. We introduced the concept of functional alignment and positioning, and one of your Canadian colleagues, when he was working with us in the UK, Justin Chang, wrote this very nice paper essentially demonstrating that you can get a knee balanced by functionally positioning it without soft tissue releases, which is one of the principles in total knee arthroplasty that we tend to follow with robotic arm assisted arthroplasty. What data do we have? I think we've got pretty good data now from multiple studies, including cadaveric studies, to basically show that if you're using a haptic controlled robotic arm, which protects the soft tissues, the saw cannot cut beyond the limit that you restrict, then you see less damage to the soft tissues and less damage to the bone. And that makes it a much more powerful intervention. It means you can preserve the PCL if you want to, and you can get the bony surfaces exactly as you want them. And that has led to philosophical change for many surgeons. People have tended to be more confident about unicompartmental arthroplasty. People have become much more confident about preserving the PCL, both because they know they can protect it, but also because they have intraoperative measures of balance that they can get feedback from. And there's been a huge push towards cementless total knee arthroplasty for many reasons, including improvements in the implants, but particularly, I think in my case, because we felt the surfaces were really good from that point of view, and we are more confident going cementless. There is other data. Again, this is our data, quite simply saying that we are able to restore anatomy much more reproducibly using a robotic arm and a CT-based plan than we did without. The secondary advantage from this is we can tell at the start of the week, we only have 5 operating rooms. I'm sure many of you have more than that, but for our 5 operating rooms, we know roughly which implant sizes we are using in every room on every day, and therefore we can predict our inventory and not run into problems from that point of view. We've done some interesting and I think quite useful level 1 studies. This is the prospective randomized study looking at the inflammatory response. It's led to a couple of publications looking at blood and drain fluid. And essentially, we've seen a diminished inflammatory response if we use robotic arm assistance compared to using manual instruments. There may be multiple reasons for that, including the haptic control, but including possibly the intramedullary use with the standard instruments. But there is definitely a signal here that we've measured reproducibly. That may or may not be one of the reasons why we have seen a better early recovery with robotic arm arthroplasty compared to manual controls. This is one paper that we published early on from Baba Kayani illustrating this, and Andreas Fontalis and the team have just looked at our entire institution over a much longer period and seen a similar signal affecting recovery, needs for physical therapy, and length of stay, improving with robotic arm assistance. And multiple others have also shown this in their centers. So this is not an isolated signal. Of course, there is always going to be some inherent bias potentially in patient selection, but the reality is the patients are staying in hospital a shorter length of time. And in our institution, we cannot have robotics in every OR. We've got 5 ORs, we've got 3 robotic arms. Inevitably, some patients are going to have manual instrumentation, even if you wanted them to have robotics. This is Andreas's paper essentially saying that advantage in a much bigger population than our initial study, and that kind of replicates what we expected from the initial data. This is quite interesting because the challenge often is whether you see a difference in clinical rather than surrogate outcomes. Now, we set ourselves to fail in arthroplasty surgery because the effect size of our interventions is so very high that actually then going beyond that and differentiating one technology from another, one technique from another is really difficult, because then you've got to be 1/3 as good again to hit MCID. So that's always going to be a tricky challenge in terms of PROMs, but the reality is we have seen improved forgotten joint scores at 5 years in this paper using robotic arm assistance compared to standard instrumentation with robotics. And the early registry data in Australia has also been very promising. Now, you've got to funnel down to the implant types that are relevant, but it's nice to see a bigger signal. The registries may be slow on this. The big databases can also be helpful. So this is from the United States, essentially a national database study showing reduced complications, including mortality, with robotic arm assistance compared to manual instrumentation. Now, remember, observational data has got its weaknesses because it wasn't designed to measure those things, but it's still useful. I think the really fun and useful thing you need to bear in mind is what might come in future, what might come in terms of surgical technique, what might come in terms of training, what might come in terms of being able to predict what each patient needs and what they will benefit from. I think the data here is so rich that we'll be able to do some incredible predictive analytics, that we will be able to look at someone's phenotype and define what kind of arthroplasty they'll do well with and how to execute it. That may feel like it's a long way away, but the power of the richness of this data with AI is going to be massive. Whilst we're doing standard things at the moment, these are studies you should expect to see some data from in the next year. So FAMA is the big randomized study that we are running, comparing functional positioning and alignment with mechanical alignment for total knee arthroplasty, both arms being done with robotic arm assistance. Now, why would we do that? This is the first time where a study will be done where you hit the target every time. We're using the same technology, but aiming for one alignment versus another. This should be very, very interesting. We should have that data with you within the next 12 months. And RACER is really interesting because it's a pragmatic, multi-center, randomized style, a study looking at robotic knee arthroplasty versus manual. It's expanding on the work that we have done in our institution, but taking that to multiple surgeons, multiple institutions to see if that will translate across multiple hospitals, multiple practices, and see if that shows a difference. Data from RACER should again be out in about 12 months' time, if not less. So it's close to recruitment. It really is in the follow-up and analysis phase now. The reality for knee arthroplasty is even the best surgeons can do better. Even if we all knew the target for every patient, we're going to hit it more often with the benefit of technology than without. But actually, there's way more. And I hope I've illustrated to you that if you have 3D planning, if you use robotic technology, you'll probably change what you do and when. You may be more confident to do more unis or more ACL preservation. You'll certainly do more PCL preservation and join that worldwide shift from PS to CR, because you'll have more confidence with cruciate retaining or medial pivot stabilized or semi-stabilized implants. I think people are going to do more cementless, and your hospital would benefit in terms of inventory and equipment. And I think the long-term goal is that each patient gets a relatively bespoke knee arthroplasty, in this case, not necessarily with a bespoke design, but with the positioning determined by their anatomy, their soft tissues, their function. So I think there's a lot to go on here, still a lot more data to get, but certainly I think we're in a more exciting and data-rich place than I expected to be at this juncture. Now, last but not least, total hip arthroplasty, worth talking about because many within our community believe that total hip arthroplasty is solved. Many believe total hip arthroplasty was solved when I was training over 30 years ago. The reality, and this paper will summarize it for you if you wish to access it in the Bone and Joint Journal, is we still have problems with hip arthroplasty. We have complications, and that may be the main thing we can address with technologies, particularly in terms of leg length, instability, and so on. But actually, we have a lot of patients with residual pain who aren't completely satisfied. We seduce ourselves that hip arthroplasty is perfect. But if you look at the data, and you see some snapshots here on the slide from our National Joint Registry PROMS program, many patients are not as satisfied or as outstanding as we think they are with total hip arthroplasty. So there is definitely room for better clinical outcomes and room for fewer complications from that point of view. That the box plot you see here from Nick Clemens' study shows you that the forgotten joint scores in their work were nowhere near the ceiling for the majority of patients. So there's definitely room for us to improve hip arthroplasty. And the way we think 3D-based planning and robotic assistance will improve it is by looking at the entire coupling and getting the center of rotation of the hip, the offset, the version, and the inclination all right. So if you like, progressing where we've been for the last 2 decades, which is essentially positioning the acetabulum at a preset value and then positioning the femur where it will go, to really thinking hard about both and looking at those two together and trying to match them to restore the patient's optimal biomechanics. And there is data here. When you look at systematic reviews, the key is to see what goes into that funnel. A lot of systematic reviews look at Robotic, old technologies that we no longer use. When you look at systematic reviews of modern technology, you'll see here that there are significant differences in relation to using robotic arm assistance, better hip scores, better leg length equalization, better acetabular position. What does that mean for patients? A couple of very interesting North American studies, basically with big numbers suggesting that the instability risk is much lower with three-dimensional planning and robotic arm assistance. Again, the weaknesses of case series and observational data sets. Well, we've done a randomized study. This was published in 2024. You'll see the infographic here and the summary. And essentially, all these patients had 3D-based planning, and one half had the operation done with robotic arm assistance, the other by experienced surgeons using a manual technique. And there were strongly significant differences in our ability to achieve the radiographic goal. Now, there is a racer hip study coming, which is powered to PROMs. This wasn't powered to PROMs, but the interesting snapshot that you can see here is from the gait data. And you'll see in the gait data that our robotic assisted hips are walking a little bit faster. Now, that needs to be replicated, but that's an interesting clinical signal which may corroborate the change in biomechanics. If we're talking this time next year, we should have the racer hip data, which will be really, really interesting. Now, as I said to you, managing beyond the effect size of hip arthroplasty is going to be even tougher than knee arthroplasty, but this will allow us to look at complications as well, and a bunch of secondary outcomes as well as forgotten joint score beyond 1 year after hip arthroplasty. So it's another big pragmatic multi-center study comparing robotics with conventional surgery, and we will report back from the UK when we have that data. The other immense power in the hip, which we're now finishing our study on, is impingement avoidance. It's being able to model motion in that hip based on this spinopelvic relationship that everybody's really interested in. So we input some spinopelvic parameters, we then look at our plan, we then move the hip, and then we adjust accordingly. And we adjust on an ongoing basis because we can fine tune during surgery. We do a femur first approach. We put the femoral broach in, we measure femoral version, and from that, we can then adjust if we need to tweak our acetabular position to something different in order to get stability and limit impingement. So the power of this is immense, but we are still learning how to use it properly. Now, the reality is you may have switched off already, or you could, if you're very kind, still be listening to me. We can, of course, continue to put in joint replacements without robots. It's done worldwide, but that ignores the direction of travel that all other industries have taken, from craftsmanship to systematic planning and execution. That may be painful for us as surgeons to accept, but the reality is we are probably better surgeons with technology than we are without it. The question isn't really whether it's going to help us, it's whether we have the appetite and whether we can afford for it to help us and whether we feel ready for it. In my experience, this innovation has given us a new outlook. I think we plan better, and that means we're starting to understand the target a lot better. When I first looked at robotics with Justin Cobb 25 years ago with Acrobot, we worked out that we had no idea what the target was. Now we have a much clearer idea, and so we know what to aim for. This is beyond accuracy. We can do dynamic assessment during the surgery, be it a hip or a knee, as I've shown you, and decide intraoperatively to fine tune, and then we can execute with much greater precision. And that allows us to make patient-specific choices, be that unicompartmental, be that the bearing size and type that makes someone's hip stable. And so we get more options, And so far, we're getting a signal for better outcomes. But as I hope you'll have appreciated, we are doing more and more studies in order to evidence that. And the other thing I haven't spoken about, but I think is going to be a huge output from this, is going to be training. It's not just our trainees understanding what they're doing in the target better. We're going to start to understand all the steps along the way of an intervention much better and be able to make people understand what they're doing and potentially what they're aiming for, and ultimately make them more efficient in their thinking and their execution. So to conclude, there is still a lot more to come, but I think this is a really interesting technology and the evidence base is now mounting. I've used this expression, which I'm going to repeat. This is the transition from craftsmanship, which is where surgery still is in many areas, to systematic planning and execution. It is something where you can have much greater confidence when you come into work about what you're trying to do that day and your ability to do it. You also are still in charge. You have feedback and flexibility to change as you go to modulate the procedure for that patient. We've got good data to show less bone and soft tissue damage. We're seeing less pain and better early recovery. And ultimately, what it's doing is it's evolving the way we're thinking about surgery and about implant choice. And it may eventually, if you don't have the regulatory framework that I have in the UK, evolve implants so that our next generation of implants are somewhat different, because they don't have to be put in with manual instruments. They could be put in with assistive technologies. I think the rest of medicine is going personalized. We probably need to be thinking about that to a certain extent. I'm sure we should be. The question really is whether we can afford it. But this is not just a good clinical tool. It's a great teaching, training, and research tool. And you will all stand at different viewpoints about where you are on this and whether you are completely dismissive, whether you're willing to listen to about it more over the next few years, or whether you're jumping to adopt it. But in reality, I think technology, our ability to plan better, our ability to execute more accurately and precisely is going to underpin our arthroplasty offering moving forward. So I hope this has been of interest to some of you. I apologize to those who are offended by my interest and the work I've done in this area. And I'm sorry we're not together in person to discuss it further, but I hope it will generate some discussions within Canada. Thank you very much.